Okay, hello everyone. Yes. Okay, hello everyone. Selamat siang, konnichiwa. I'm so grateful that today we can gather here in this guest lecture sessions. I hope everybody is in healthy condition. The theme of this today's guest lecture is update in liver pathology. And this guest lecture is presented by Department of Anatomical Pathology and also Department of Clinical Pathology that is supported by guest lecture and visiting Professor grant by Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. I welcome everybody's here, especially our speakers and moderator, Professor Ikuo Shoji, and then Dr. Dewiyani Indah Widasari, specialist pathology anatomy, and also Dr. Gandi as a moderator. Actually, Prof. Shoji has visited our institution for several times, but due to pandemic, this year we meet virtually in these guest lecture sessions. Okay, and also our warmest welcome for our participants. Thank you for joining these guest lecture sessions. And Bapak Ibu sekalian, ladies and gentlemen, today's lecture will be moderated by Dr. Gandi. Please share slide. This is the itinerary for today. Later will be read by Dr. Gandi. I will read Dr. Gandi's speech as a moderator. Dr. Gandi is completed his medical. Please next slide. Dr. Gandi completed his medical doctor in 2013 in Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. And he completed his PhD in 2020 this year in Kobe University Graduate School of Medicine. And currently he is in a postdoctoral fellowship in Kobe University under supervision of Professor Shoji. So I will leave this guest lecture session to moderator. Dr. Gandi, please, time is yours.
Okay, thank you very much, Dr. Eri, for the nice introduction. Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Rheza Gandi Bawono, and first of all, I would like to welcome you all today international guest lecture with the title Updates in Liver Pathology. And here is our today's international guest lecture itinerary. Please the next slide. So now we are in the participants enter Zoom, and after that the opening from the Dr. Eri, and from the 1 p.m. 5 minutes until 1:10 we have the guest lecture opening by me, and then the next from 1 p.m. 10 and until the 1 p.m. 40 we have the first session from the Professor Ikuo Shoji MD Ph.D. with the title of the ISGylation function as the proviral factor for the hepatitis C virus and hepatitis B virus. And for the next session in the 1:40 until 2:10, we have the second session with the title Liver Pathology Diagnosis, Hospital-Based Experience in the Dr. Sardjito General Hospital, and presented by the Dr. Dewiyani Indah Widasari. And after that, and from the 2:10 until 2:30, we will have the discussion session. And after that, in the 2:30, we will have the closing session. On the next slide, please. So before continuing to the next session, I would like to read today's international guest lecture rules. First is set up your Zoom name with the institution and the full name. And the second is the question can be asked on the live chat room in the Zoom room with the following format. First, nickname, and then slash the speakers, and then slash the question. And the question will be answered in the discussion section, in the end of the discussion session. And next, please. So before the presentation began, I would like to introduce our first speaker. Our first speaker is the Professor Ikuo Shoji MD PhD. And Professor Ikuo Shoji got the MD from the Kobe University and also PhD from the Kyoto University. And currently, Professor Shoji is a professor of the Division of the Infectious Disease Control, Center for Infectious Disease, Kobe University Graduate School of Medicine. He is also the Vice Dean for the Kobe University Graduate School of the Medicine. Professor Ikuo Shoji has the H index of the 36 and has the 77 original article and the 7 review article. All right, without any further ado, I would like to welcome our first presenter, Professor Ikuo Shoji. The time is yours.
Sensei, you are still muted. I'm sorry.
Okay, sorry. Good afternoon, everybody. I'm Ikuo Shoji, Kobe University. I'd like to thank the organizers for giving me a chance to share our data in the webinar of UGM. So let me share my slide. Okay. 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 Today I'm going to tell you about the isolation functions as a proviral factor for hepatitis C virus and hepatitis B virus. Okay. So in the beginning, so as you know, there are 5 human hepatitis viruses from hepatitis A to hepatitis E viruses. And today's topics are about HBV and HCV. And as you know, HBV is a DNA virus and carrying the partially double-stranded circular DNA as a genome with 3.2 kilobases. And HBV has S protein as an envelope protein and belongs to Hepatodonaviridae family, also hepatodonavirus genus. And HBV transmits through blood and body fluid, and it can cause hepatocellular carcinoma. And HCV is a positive strand, single-stranded RNA virus with the genome of 9.6 kilobase. And the E1, E2 protein, glycoproteins are the envelope proteins. And HCV belongs to Flaviviridae family, Hepatovirus genus. And HCV also transmits through blood and body fluid. And HCV also causes hepatocellular carcinoma. And so HBV and HCV are the oncogenic viruses. So this cartoon shows the genome structure of HCV genome. And HCV is a positive stranded RNA virus. And it has very characteristic 5' end and 3' end. And 5' end function as a iris function, internal ribosome entry site, and 3' end has a very interesting structure, and which is very important for HCV replication. And HCV genome functioned as a mRNA and produce one single polyprotein. And this one big polyprotein is cleaved by cellular signalases and also cleaved by viral protease, NS2 protease, and NS3-POA proteases. And today's topics is ISGylation. And IST15, interferon stimulated gene 15, is a ubiquitin-like protein. And IC15 is induced by type 1 and type 3 interferon and functions as a protein modification system, which is known as ISGylation. This is an enzymatic reaction, and there are several key players, E1, E2, E3, and these enzymes function in a cascade, and the IC15 is activated, and the E1 transfer IC15 to E2, and the E2 transfer IC15 to E3, and finally, E3 put IC15 covalently to the substrate through the lysine residues. And another important key player is USP18. USP18 removes IC15 from the substrate. It's called the ISGylated enzyme. So these balance important for ISGylation. And ISGylation is known as antiviral factors for many viruses. For example, herpes simplex virus and influenza virus, shingles virus, chikungunya virus, JEV, Japanese encephalitis virus, dengue virus, West Nile virus, and the Ebola virus. However, there is a discussion that in HCV infection, ISG15 function as proviral factor and antiviral factor, and this controversial discussion remains. And we ask the question whether ISGylation function as a proviral factor or antiviral factor. So this work was done by Dr. Takayuki Abe, associate professor in my laboratory. And in the beginning, he tried to identify which viral proteins are ISGylated. And he found that NS5A protein is ISGylated. As you can see here, NS5A protein is shifted in the presence of E1, E2, E3, and ISG15. So the slowly migrated form, ISG15 conjugated form of NS5A were detected if you put the important factors for ISGylation. And there are 3 known E3 ligases for ISGylation. So the HAC5, TRIM25, and HHARI. And the next, we examined which E3 ligase is involved in the ISGylation of NS5A. So if you, when you put the different E3, HAC5, TRIM25, and HHARI, and you can find the ISGylated NS5A only in the presence of HAC5. So this suggests that HAC5 is the E3 ligase for NS5A ISGylation. And the NS5A, so we use the CON1 strain, which is 1B strain of HCV, and NS5A of CON1 has 13 lysine residues. And this cartoon shows the structure of NS5A protein, and in the domain 1, domain 2, and domain 3, and you can find 13 lysine residues. And in the beginning, we made a mutant which don't have any lysine residues, and we put it back each lysine residues at lysine 44 and each site, and we made a series of mutant of NS5A. And we can find that lysine 44, 68, 166, 215, 308 can accept ISGylation. And I don't show the data, other data, but the other lysine residues are not the acceptor sites for ISGylation. So then we examine the role of these lysine residues, and we mutated these lysine residues, and we found that lysine 166 and lysine 215 and lysine 308 are important for replication of HCV. So here we use the subgenomic replicon, and which replicates. And if you put the mutation in the 3 lysine residues, this replicon cannot replicate anymore. So this means that these 3 lysine residues are important for HCV RNA replication. Then to understand the mechanism of the ISGylation and HCV replication, and we take a look at the lysine residues important for replication. And this cartoon shows that this lysine 308 resides in the region of cyclophilin A binding region, and cyclophilin A is known to play a very important role in HCV replication, and cyclophilin A binds to NS5A protein and assist the HCV replication. And several papers shows that cyclophilin A is important host factor for HCV replication. And we found that important isolated lysine resides in this region. And we ask a question whether the isolation of NS5A may have a role, the interaction between NS5A protein and cyclophilin A protein. Then we made a couple of experiments, and so this is the immunoprecipitation analysis. And when we put the isolated important factors, and we can see the interaction was promoted in the presence of isolation factors. And also, this experiment is a PLA assay, and we look at the NS5A cyclophilin A interaction, and then you can find a signal in the presence of isolation factors. In the absence of isolation, we cannot see many signals. So this means that isolation promoted interaction between NS5A protein and cyclophilin A. So here is one conclusion that HCV1B NS5A protein can accept isolation at several lysine residues, and at lysine 166, 215, and 308 are important for HCV RNA replication and function as a proviral factor. And our experiment shows that isolation is important for the interaction between NS5A protein and cyclophilin A, which is a very important host factor for HCV replication. And HCV has many genotypes, and we ask a question: whether this mechanism also important in different HCV genotypes. So this cartoon shows the NS5A protein genotype 1B, 1A, 2A, 3A, 4A, and 5A. And each NS5A protein carries 14, 13, 15, 16, 19, and 16 lysine residues. And the interesting thing is the only genotype 2A doesn't have a lysine residue at domain 2. although other genotypes, HCV genotypes, carries this lysine 308, which is important for HCV replication. So this findings suggest that genotype 2A may have different ways to promote HCV replication. But probably in other HCV genotypes, the isolation at lysine 308 is important for HCV replication. So then we check the isolation of each HCV genotype, and we found that other genotypes HCV NS5A proteins are also isolated, but a slightly different manner. And the interesting thing is genotype 2A HCV NS5A is also isolated. Okay. Then we take a look at the whether isolation promotes the interaction between NS5A protein and Sp.PA protein. And as you can see here, genotype 1A and genotype 3A isolation promoted interaction between NS5A and Sp.PA. And however, the genotype 2A doesn't have a lysine at domain 2. And so we introduced a mutation and to map the important lysine residues on genotype 2A HCV. And we found that lysine 26, 139 are important for isolation. So as you can see here, the mutant, in the mutant, the isolated bands disappeared. Then we look at the HCV propagation, and we stain the HCV core protein in the mutant HCV, and when we introduce the mutation at lysine 26 of NS5A, so that this virus replication level was decreased significantly. And as you can see here, and the HCV titer was also decreased to 1/10. And as you, the replication level was dramatically reduced by the mutation. And when we made a double mutant of NS5A of HCV 2A, and a double mutant completely disrupted the HCV propagation, as you can see here. So these results indicates that isolation of NS5A protein of HCV2A also are important for HCV replication. So here is the conclusion of the second part. And NS5A protein from HCV, other HCV genotypes also accept isolation at lysine residues, but in a different pattern. And NS5A from HCV genotypes also show the enhancement of the interaction between Sp.PA and NS5A when you promoted the isolation. So that in a case of genotype 2A, the lysine 26 and lysine 139 accept isolation, And these are very important for HCV replication and propagation. Here is our current model, and in the genotype 1B and almost all the genotypes, the domain 2 of NS5A is isolated, and this isolation promotes the interaction between NS5A protein and scleropirin A, and that's why isolation functions as a proviral factor for HCV replication. And the NS2A use different lysine residues to promote replication by isolation. Okay, second topic, probably Gandhi-san should talk instead of me, but I will introduce his thesis work. And so then we ask a question whether isolation may have a role in HBV replication. And HBV is a DNA virus, and the genome size is just 3.2 kilobases, and the small virus, small DNA virus. And HBV has 4 viral proteins: HBS protein, HBV polymerase, and HBC protein, and HBX proteins. So as you know, HBX is important for hepatocarcinogenesis and also promote HBV replication. Then we ask a question, which viral protein is isolated? And then we ask a question, isolation may function as a antiviral function or proviral function. So HBX is 154 amino acid protein, and in the N-terminal region has a regulatory domain, and the C-terminal region functions as transactivation domain. And HBX promote the transcription of other genes, and promote also promote the viral replication. And the HBX protein carries 6 lysine residues in the transactivation domain. And when we performed the experiment, and we added E1, E2, E3, and the IC15, we found that HBX protein are isolated, as you can see here. You can see many radar bands like this. And when we use the IC50 mutant, which whose glycine residues mutated to alanine, this IC15 cannot covalently bind to HBX protein. So you cannot see any isolated band of HBX protein. So this data shows that actually HBX protein is isolated, and probably at multiple sites. And then we use the PUC-HBV. This plasmid, when we transfect this plasmid, the liver tissue culture cells can produce HBV virus. And we transfect PUC-HBX to HH7.5 cells, and you can see the isolated HBX protein. And when we use the PUC-HBV delta HBX, so this plasmid carry the mutation at the methionine colon of HBX, so the HBX cannot express in this from this plasmid. and you cannot see any radar bands here. So this result suggests that HBx protein produced from HBV virus are also isolated, as you can see here. Then we asked the question, which E3 ligase is important for isolation of HBx protein. And so we also found very similar data to HCV, and the HAC5 E3 ligase for many proteins is important for isolation of HBx protein. But the other E3 ligases have no roles in HBx isolation. Then we put the mutation at the catalytic cysteine of HAC5, and this mutant cannot put the AST15 to HBx protein. So this result indicates that HAC5 enzymatic activity is important for isolation of HBx protein. Okay, so then we checked whether the isolation machineries are important for isolation of HBx protein, and we removed E2, and isolation was dramatically reduced. And when we removed HAC5 and UBCH8, E2 and E3, we cannot see isolated bands. So these shifted bands are actually the isolated HBx protein. So this cartoon shows the alignment of HBx protein, and we compared 4 different genotypes of HBx protein. And as you can see here, most of the lysine residues are conserved among 4 different genotypes. But however, only this one, genotype B, don't have lysine at 118, but the other 3 genotypes carries lysine residues at 118 lysine site. Then we take a look at the HBx isolation, and as you can see here, HBx proteins are isolated, and protein ladders of isolated HBx were visible in all 4 HBx proteins. Then we mapped which lysine residues are important for HBx isolation. And when we introduced the mutation at lysine 91, 95, and 140, the isolated bands clearly disappeared. So this result indicates that lysine 91, 95, and 140 are important for HBx isolation. Now, when we introduced the mutation to HBV plasmid, and this mutant didn't replicate at all, which is very surprising. And this data clearly suggests that these 3 lysine residues are important for HBV replication. And what we found is HBx isolation is important for HBV replication, but the mechanism underlying the isolation of HBx for HBV replication still remains unclear. And we examined several important issues. And in the beginning, we examined the subcellular localization of HBx protein. And when we put the isolation machinery, so nuclear localization of HBx protein was elevated and compared to the in the absence of isolation. So this data suggests that isolation of HBx may be important for nuclear localization of HBx protein. Now, another important issue is resistant to interferons. So we use the type 1 interferon alpha and interferon beta, and also we check the type 3 interferon, IL-28A, 28A, and 28B, and IL-29. And so when we put the interferons and to the Hepatitis NTCP cells carrying the PUC HBV plasmid, and this plasmid produce the HBV virus, and we take a look at whether these cytokines inhibit the replication. And but as you can see here, the type 1 interferon and the type 3 interferons have partial effects on the HBV replication. And in contrast, HCV, in case of HCV, these interferons inhibited HCV replication in HCV subgenomic replicon cells. But as you can see here, in HBV replicating cells, these interferon, type 1 interferon and type 3 interferons have a very much less effect on HBV replication. So this may be important, and isolation may play a role in the resistance to type 1 and type 3 interferons. But we have to do more experiments to make this clear. Then we ask a question whether isolation is important for HBV replication. And when we knock down ISG15 using siRNA, and if we knock down ISG15, the HBV replication was decreased. So this suggests that ISG15 is important proviral factor for HBV replication. Then we also knock down the USP18. USP18 is a counterpart of ISGylation. So a USP15 is a protease that cleaves the covalently binding IC15 from the substrate. And if we knock down USP18, inhibitor for IC15 will disappear. So HBV replication was increased. So this suggests that IC15 is a proviral factor for HBV replication. Okay, taken together, we concluded that HBx protein can accept isolation at lysine 91, 95, and lysine 140 of HBx protein. And HAC5 is a specific E3 ligase for HBx isolation. and HBV exhibited resistance to the treatment of type 1 and type 3 interferons. And HBx isolation may contribute to a proviral function for HBV replication, as well as resistance to interferon response. And then now currently we are screening for the HAK5 inhibitors and to examine the inhibitory effect for HBV replication. And HAK5 may be an attractive therapeutic target for the treatment of chronic HBV infection. So here is our current model of isolation and HBV replication. And HBx protein is isolated, and this isolation function as a proviral factor and may have some role in interferon resistance. So further studies will be needed to elucidate this function. Okay, thank you very much. This work was done by Dr. Abe and Dr. Gandi-san, and Adi-san, Aulia-san are doing very well, and Putu-san from Udayana University, she works on HCV. And this year we have a meeting in Kobe, but a virtual meeting. And this photo shows a meeting in Tokyo. And we hope to go to travel all around Japan, as well as all around the world in the near future. And Dr. Matsui is an assistant professor of my laboratory, and Dr. Dan is also an assistant professor in my laboratory. Okay, here is my collaborators and the funding agencies. Thank you very much for your attention.
Thank you very much for your excellent presentation, Professor Ikuo Shoji. So there are so much interesting knowledge and the insight that we can gain from your excellent presentation today. So it is interesting how the ISGylation has the proviral effects on the HCV and HBV infection, whereas it has the antiviral function to many viruses. And to save the time, so next I would like to welcome to our second speaker, Dr. Dewiyani Indah Widasari, MD, Sp.PA, Ph.D. So she is a medical staff department of the anatomical pathology, Dr. Sardjito General Hospital, Faculty of Medicine, Public Health and Nursing, UGM, and also research and development sub-coordinator in the Dr. Sardjito Hospital. Dr. Dewiyani graduated from the Universitas Gadjah Mada in 2005 and got the pathologist from the Universitas Gadjah Mada in 2010, and also Ph.D. from the Kobe University in 2014. She has the AIDS index corpus of 6 and then 49 publication. Now I would like to welcome our second presenter, Dr. Dewiyani Indah Widasari. The floor is yours.
Thank you very much, Dr. Gandi, for the very kind introduction. Can you hear my voice? Is it okay?
Yes, we can hear clearly your voice.
Okay.
Please, Doctor.
I would like to share my screen. Okay. Okay, thank you very much. First of all, I would like to greet our distinguished speaker, Prof. Ikuo Shoji. It is such an honor for me to be here with you today. And also thank you very much for the organizing committee, Dr. Eri and team, for the opportunity to speak here today about the hospital-based experiences from Dr. Sardjito Hospital about liver pathology diagnosis. Okay, I will start my presentation with a little introduction about our hospital. So Dr. Sardjito Hospital is a general hospital owned by the Ministry of Health, and it is a national tertiary referral hospital in Yogyakarta area. And also it is a referral for patients from South Central of Java. So quite a large area from Java. Oh, sorry. And it is also the main teaching hospital of Faculty of Medicine, Public Health and Nursing Universitas Gadjah Mada. So we usually have around 1,000 residents doing activity in our hospital. And also we have interns and some nurse students. So it is very, it is a very crowded, no, not crowded, but it's very, lots of people in the hospital. And it has around 800 beds, and we have lots of doctors and lots of sub-coordinators. Okay. So I will start for you about the activities in our department of pathology, anatomical pathology. We have total annually about 12,000 specimens. That includes of histopathology specimens, and also cytology and immunohistochemistry, fine needle aspiration biopsy, histochemistry, frozen sections, and rapid on-site evaluations, and also external consultations and confirmation. So it is quite busy in our department. This is our liver specimen examinations, especially because this is about liver. So I would like to explain about how much maybe specimens we check out annually. So usually it is around the 145 this year, and plus it is tumor about 52% and non-tumor, and also cytology, the malignant and benign is also not quite different in the incidency. Okay, we also have as a referral hospital liver tissue specimen examinations because we also have a center of liver transplant, then lots of liver tissue from pediatric pathology, and this is the distribution of the cases, around 103 adult cases and 42 pediatric cases. And most of it is about hepatocellular carcinoma for the malignancy and other malignancies. And also we have quite lots of chronic hepatitis or liver diseases and other benign lesions also. So this is quite interesting because we tried to find data about how many patients of hepatitis are there annually we can find in Sardjito. So based on the ICD-10 code, it is quite interesting that the acute hepatitis B is plenty of patients. So annually there are 305 new patients, and on chronic viral hepatitis is around 594 that we found. And also interesting that it is a hepatocellular carcinoma with chronic HBV. We have data on 74 patients. So I think this is a very open space for us to do very much research on hepatitis. Maybe I would like to share some studies that we have done previously. It was maybe quite long ago. So I think in this opportunity with Professor Shoji, maybe there will be an open opportunity to have more researches in the future on hepatitis. We also have around 8 gastrohepatoenterologists, and we have 4 surgeons, digestive surgeons. So I think it is an open opportunity for having lots of research in this field. Okay, maybe I will try to share some cases that we usually see in the hospital settings. Maybe, I'm sorry, Professor Shoji, because it's not quite deep in the molecular basis, but maybe this is for the, you can see how it is in the hospital. So, well, as we know that the liver cancer is the second most cause of the cancer-related death worldwide. And here we have the hepatocellular carcinoma. And lots of, like we mentioned before, we see lots of HPV-related hepatocellular carcinoma. So I think it is very interesting for us to see some cases. So this is a case of a male. In 2006, he was confirmed with HBV infection. And then on January, he was diagnosed with diabetes mellitus, and also he had an abdominal distension. Then on May, it was progressed, and he had acid test and evasion pleural, and also the distension prolonged, and he was referred to our hospital. So this is very common in our hospital because it is the referral hospital. Usually the patients come from the secondary hospital, and then if they become more progressive, then they will go to the hospital. So it is maybe not fortunate for us to have patients that usually are already in severe cases. So the patient was evaluated by the digestive surgeon. So and then he went on imaging examinations, and the laboratory all suggested that it can be confirmed that he was HPV related, and the digestive surgeon had the laparotomy exploration and the debridement. It was sent to us materials of liver biopsy and some cytology from acetic fluid and also some effusion fluid. Okay. So this is a typical case of the hepatocellular carcinoma. We see the tumors, and also we can see the chronic hepatitis inflammation, interface hepatitis, and there is the trabecular growth and pattern and the thickened cells, and also it is very atypical with coarse nuclei and prominent. So this is hepatocellular carcinoma, and also there's a bile production. And in another part of the tumor, it also has conditions that were not malignant, and it still shows some chronic hepatitis B patterns. So this we can confirm as a HBV-related hepatocellular carcinoma. And also in the cytology, we find we received yellow fluid with clear in color, lots of atopia cells, polygonal cells, and eosinophilic granulocytoplasms. We can conclude it as a malignant cell. And also in the acetic fluid, there was also many atypic cells. So it has metastasized into the acetic cover. And it was diagnosed as malignant also. So that was a typical case of hepatocellular carcinoma. And we have, I think, many cases in our hospital. And as we mentioned that it is very unfortunate because usually the patients come to our hospital at a severe phase. So it's not very good for the patient prognosis. Okay, maybe next I would like to present other malignancies of the liver. So this is a male, a case, 92 years old. And we have this as a confirmation from the referral hospital, the second referral hospital. So there it's shown to be mesenchymal spindle cell tumor. And because usually the second referral hospitals do not have methods to diagnose, usually they bring the specimens to our hospital and we can do the diagnosis like immunohistochemistry or maybe the molecular pathology. So based on this case, we can see lots of liver tissue, but with bundles that stores, and we can see the surrounding liver connective tissue, and there is blood vessels that forms like Stackhorn's images. So, and also if we see clearer, we can see lots of dominant spindle cells with fusiform coarse chromatin and also hyperchromatic nucleoli with mitosis. So we can assume that this is a malignant tumor. More atypic cells with hyperchromatic nucleoli and also mitosis. So this is a very nice systematic review from Martins et al. In 2020 that the most common histological types of primary sarcoma in the liver is angiosarcoma and then leiomyosarcoma and epithelioid endothelioma and embryosarcoma. So as the basis from the case, we try to make the diagnosis, the evidence diagnosis, and examining the immunohistochemistry. So we use the Jasmine and it stains positive for the tumor cells, and DOC1 for GIST, it stains negative. Usually we also can do CD117 because it is also connected to the therapy, but in this case we did DOC1 and it was negative. And also CD34 was negative in all the tumors, but positive in the endothelial cells. So we concluded negative. And we see here the Ki67 is almost most of the cells. So we counted around 75%. From this case, we suggest it is a leiomyosarcoma because based on the Jasmine positive for the leiomyomas, and they are negative for DOC1 and CD34. So this is a typical case that we usually see, and we usually do the panel of immunohistochemistry for spindle cells or mesenchymal cells in the liver. Okay, so this is quite an interesting discussion. So now we are in the urge of the molecular pathology era, and we know that it is a personalized therapy. So nowadays we have to go beyond, and we have to go out of the box, because in our condition with limited resources, then it is very expensive to do molecular pathology. So here in Sardjito Hospital, fine needle aspiration examinations is more favorable because it is cheaper and also less invasive. And we also do it very common in the Sardjito settings. And many references state that the molecular examination can also be done from cytology examination. Many references say that even the cytology is better because they do not be fixated by the formalin that does not ruin the RNA and DNA. So it is much, in a proper way, it is better than if we do it in the histopathological PPFE. Okay, and the DNA is also in good quantity and quality, and it is very recommended to use for the new generation sequence, irrespective for the type of the fixation. And but but the yield of the DNA is, it has a correlation with the pattern of the tumor. So the pre-analytic phase of doing this molecular pathology or cytology to examine the molecular pathology is very important. Okay, this is a study that shows how we could recognize the feasibility of the specimens. So in this area here, this usually we can also have this kind of specimens. It is said that in the left specimen, it's too small tumor. So we can reckon that maybe you will need at least 50 unstained slides if you have slides like this or specimens like this. So it is also important how to make the slides in the cytology phase. And in the second left here, usually it is said that at least 10 to 15 unstained slides if you have specimens as big as this, and maybe only 40% of it is the tumor. So it can be mixed with other cells. And maybe if we have slides very thick like this, it can contain cells, but it is very hard to remain, and you will need quite a lot of slides also, because maybe you will have to get the cells in a very hard way. So the best smear that this study recommends is very slight and maybe long smears. So the cells that connect to the slide will be more easy to get. And usually you can remain 2 or 3 smears of this type of slides. So the molecular adequacy of the cytology specimens very correlates with the overall cellularity of the tumor fraction itself. So it is very important of the pre-analytical phase that we have to try to make the specimens as nice as possible. So the use of the cytology specimens for the molecular pathology biomarker testing, it can provide personalized diagnostics. And usually it is also for the prognostic and the therapeutic information for the clinicians. As in our experience, it is usually common to use this cytology type for molecular examinations for non-small lung cell carcinoma. So it is very useful for the clinicians and the patients. Careful attention to triaging specimens. It can maximize the yield and minimally invasive cytology specimens to reduce the need for the rebiopsy. So we also use the rapid on-site evaluation when we do this cytology to get the cells. So we hope that when we do the examination, then it will not be necessary to do another rebiopsy, or we have to take the patient back to the ward and then come and take them back to the site for the rebiopsy. So it is very useful to use the rapid on-site evaluation. And then it is also said that the cytology of the forefront of the molecular testing in the lung and thyroid is still fixated of FK-PA, but in our center, we already use the cytology, but it is still also okay to use the FK-PA, although some references say that the quality of the DNA or RNA is better from the cytology because of the fixation of the formalin. And in this case, in our condition with molecular being held from cytology, so the pathologists have a really important role to play in the future of molecular testing. So by guiding their clinical colleagues toward the appropriate use of the cytology specimens and for molecular testing, and by participating in studies to define the performance of these molecular tests of cytology specimens. So it will become a better use in the future and more effectively and more minimal invasively for the better conditions for patients. So like we mentioned before, we already have the implementation of molecular examination in our center in Sardjito Hospital and Faculty of Medicine, UGM. And already we do routinely on the lung cancer and thyroid cancer. And it is very useful for patients. And in liver cases, there has been some experience, but not done routinely for HBV and autoimmune hepatitis. This is our team in the pathology department. So we have 12 staff members and also 18 residents, fellow residents here. We go along very well, and we get busy on doing the pathology specimen examinations. Okay, I think that is all for my talk. I think we can have discussions on this matter, and I hope we can have a good, fruitful discussion. And this is Kobe at the evening, so I would also like to come to Kobe if there is an opportunity. Okay, thank you very much, and thank you for the opportunity. Thank you. I will turn back time to Dr. Gandi. Thank you.
Okay, thank you very much, Dr. Dewiyani, for your very interesting and very informative presentation about your hospital-based experience in the liver pathology. So your department has done a great effort on the diagnosis of the various diseases, and the arch of the molecular pathology is very important and beneficial for the both for the patient and pathologist. Thank you very much, Dr. Dewiyani. So next, before we move to the next session, we will have a photo session. Please, to all the speakers and the participants, please turn on your video, and our host will take the screenshot for our photo session. Mohon perhatian untuk Bapak Ibu sekalian, dimohon untuk menghidupkan videonya karena akan dilakukan sesi foto bersama. Terima kasih sebelumnya. Silakan kepada host acara untuk memandu jalannya foto sesi.
Okay, let's take a photo together. Maybe we will take several photos as we don't have enough screen space for all. Yeah, the first session will begin in 3, 2, 1, and smile. Okay, another. Okay, in 3, 2, 1, smile. Yeah, thank you very much.
Okay, thank you very much for everyone. So, all right, ladies and gentlemen, and now we come to our next session, the discussion session. So please put your question in the chat. And I think we already have several questions. Please, Ronnie, please, can you please show us the question from the audience? Okay, so yeah, we have the 3 questions for the discussion. The first question is for the Professor Shoji, so from the Maria Aletheia. So good afternoon, Professor Shoji. Maria Aletheia have the question regarding the ISGylation process. Are there any other amino acids that are important in ISGylation process besides the lysine residue? Thank you very much. So
okay, yeah. Okay. Yeah, this is very important question and a good question. And in the ubiquitination, main acceptor site is lysine residues, and but in the rare case, the methionine accepts isolation in linear type ubiquitination, and So in the ISGylation, other amino acids may be able to accept ISG15, but in our experiment, we made a lysine-less NS5A, and we couldn't see any isolation. So therefore, we think that lysine residues are only site for isolation in NS5A. But so in several atypical ubiquitination, other amino acids can accept ubiquitin. So yeah, we have to rule out that the other amino acids may be able to accept isolation. But in our experiment, we show that lysine-less NS5A has no shifted bands. So the data support our idea that isolation occurs only at lysine residues. Okay, thank you. Welcome to Japan. Are you around Narita Airport now?
It's in quarantine, Prof.
In quarantine.
When the quarantine period ends?
12月2日です。
あ、すごい。日本語だ。
日本語上手。
上手です。
We are looking forward to seeing you soon.
I'm looking forward to learn from you soon, Sensei.
Okay.
Thank you very much, Professor Shoji. And for the next questions, please. So the next question is from the Koironi to the Professor Shoji. So I would like to ask how do these findings about ISGylation could help in the development of the antiviral drugs for hepatitis treatment? Is there any current drugs developed from the findings? Thank you very much.
Okay. Can you show that question again? Can you show the slide? Drug development. Okay. Yeah. ISGylation. So I didn't mention that, but HAK5 is also interferon inducible gene. So in the absence of infection or some activation of interferon system, HAK5 didn't express in the cells. So if we target HAK5, that don't we think that inhibition of HAK5 has no side effects for the physiological condition. So we think that the HAK5 may be a good target for anti-HBV or HCV therapeutics. And the HAK5 inhibitor is reported from one Chinese group. And now we collaborate with Kobe College of Pharmacy and synthesize HAK5 inhibitor and also made several derivatives of that inhibitor. And we currently examine the inhibitory effect of HAK5 in HBV and HCV replication.
Thank you very much, Professor Shoji. So we would like to the third question from the Budi Herianto. So to Professor Shoji. So I would like to ask about the connection between the ISGylation in the pathologic process in the liver pathology, especially in chronic viral hepatitis. Can we have some advantage from the ISGylation to diminish mortality and morbidity in chronic viral liver hepatitis? Thank you very much, Professor.
Yeah, that's a very good question. And so as you probably know, ubiquitin and the ubiquitin system plays an important role in carcinogenesis. And I did postdoctoral training at Harvard Medical School at Peter Howley's laboratory. So Peter Howley's laboratory discovered that human papillomavirus 16E6 promotes ubiquitin-dependent degradation of p53, and so the and also many researchers reported that cell cycle regulators are regulated by ubiquitin system. And the ISG15 is a ubiquitin-like protein, and ubiquitin-like proteins play a very important role regulating the protein's functions. And currently, we don't know how ISG15 is involved in hepatocarcinogenesis. But one paper was published several years ago, and they reported that the ISGylation promotes the p53 degradation. And so actually that group created, synthesized the HAK5 inhibitor to use as an anti-liver cancer drug. And but we didn't know the next report from that laboratory. I don't know what the outcome is like. So currently it's not easy to apply this knowledge for cancer therapy or cancer prevention, but maybe ISGylation and other ubiquitin-like protein modification play an important role in pathogenesis. So we should accumulate more knowledge in this field.
Okay, thank you very much, Professor Shoji, for the thoughtful answer. So now we move to the next questions from the Kurotun Aini to the Dr. Dewiyani. So I would like to ask Dr. Dewiyani how to distinguish in cytology between the normal hepar and well-differentiated hepatocellular carcinoma. Thank you, Doctor.
Okay, thank you very much, Dr. Aini, for the question. So it is very interesting because it is a challenge in the fine needle aspiration biopsy for the identification, because we know that the liver has many lesions, and before becoming malignant, usually they have reactive nodules, and maybe they have dysplasia in the nodules, and many conditions that maybe some adenoma with reactive cells also is a very challenging method to distinguish the normal cells and the well-differentiated cells. But we can we have to see also the clinical condition and also the laboratorial findings. So we cannot only see by the cytology, because it is only a small amount of cells. So it is, I think we still have to see the liver functions and the laboratorium conditions and the laboratory conditions, and also the clinic. Is there a nodule in the examination, or is there a condition that may be a high AFP, or conditions that may seem to have a malignancy? Then we have to say that it was tend to be a malignant cells, but we cannot say it as a golden standard, because it still needs the biopsy to be the golden standard if it is the malignant cells or not. So I think that is how we answer. So we cannot be too brave to say that it is malignant, but we also have to see all the conditions and the clinical conditions to have a proper diagnosis. I hope it can answer Dr. Aini.
Thank you very much, Dr. Dewiyani, for the answer. So next, we would like to move to the fifth question from the Telazia Kalkarinaji to the Dr. Dewiyani. So I would like to ask the questions: how to diagnose the hepatocellular carcinoma in peripheral hospital? Do we still need immunochemistry staining, doctor? Thank you.
Okay, so if we are a pathologist in the maybe remote area, so we do not have any immunohistochemistry, then we still have to always see the clinical conditions of the patient. Is there any lesions, or is there any conditions that they have a post condition of maybe hepatitis, or maybe some conditions that may lead to the malignancy. But if the laboratorium is maybe safe, then I think it is clear that we also see the radiology and also the other examinations. I think if it's a single nodule and all the clinic findings can lead to the malignancy of the liver, then maybe it's we can conclude it as a hepatocellular carcinoma. But if we see other conditions or lesions in other places, then think about the metastasis. Then I think you should have to do some other examinations in the biopsy. If it's it can be distinguished on the hepatocellular carcinoma and other adenocarcinoma, but sometimes when it's hard to distinguish, then I think immunohistochemistry, you have to do the examination so we can have the proper diagnosis. But usually if the clinical conditions is leading to the hepatocellular carcinoma, then you don't have to do the immunohistochemistry. Okay, I think that's what I can answer. Thank you very much.
Thank you very much, Dr. Dewiyani, for your answer. So it is very interesting. So is there any other questions? Is there any other question from the audience? Please, you can, we still have some time for the questions.
Can I ask Prof. Shoji?
Yes.
Maybe it's not related to HPV or hepatitis C, but about COVID. Is it because you are very expert in virology? Do you also do research on COVID, Prof?
COVID.
Yeah.
Actually, Aulia-san is working on COVID-19,
Oh, really?
and so it's a very similar method. And Dr. Abe and Aulia-san is now looking at. Yeah, Aulia-san, you should answer instead of me. And, she is looking for any viral proteins are ISGylation, and she is doing a cloning, subcloning of viral protein of SARS-CoV-2, and she discovered the one important viral protein is ISGylation, and that may be important for infection of SARS-CoV-2. Now, she's doing a lot of work.
Thank you very much.
I hope the research going well and give a good result. Sensei.
Yes.
This field is very competitive, and
yes, because everybody now has research on this COVID.
Yeah.
Yes. So
are doing the similar things. So Dr. Abe is a really hard worker. That's why Gandhi-san lost weight.
Yeah, 9 kilogram.
Yeah, so now Arya-san has to work with Dr. Abe. She may have a, I don't know, but she may have a tough time.
We lose weight also.
Currently, probably okay. Everything seems okay.
Yes, hopefully. Dr. Deviani, maybe you want to ask something?
Oh yes, maybe for Prof. Shoji and Dr. Gandhi. So as I mentioned, actually the field in hepatitis in Sardjito is actually, I think, lots of things that we can research on, because I think there is lack of research about the hepatitis here. So I hope when Dr. Gandhi, are you coming back to Yogyakarta? Or
Are you going back?
I hope we can have lots of collaboration and research in the future.
Yes.
Thank you.
Yeah.
His wife has to finish her PhD. So,
Yes.
so Gandhi-san has to take care of his children.
Yes. Yes, Sensei.
So I hope when we go back to the UGM, so we will have the good research on the HPV or HCV field.
Yes, I hope so.
So with the pathological anatomy department and also to the Kobe University. Okay, everyone. So I think we are already at the end of the discussion session. So thank you very much for the Professor Ikuo Shoji for your insights. We still have a lot of things to learn about the ISGylation on the HCV and HPV infection and their impact to the patients. So, and also thank you very much to the Dr. Dewiyani for your hospital-based experience that are very useful for the doctor in Indonesia. So I hope everything's, I hope this international chess lecture will be beneficial for everyone. So ladies and gentlemen, finally we come to the end of the presentation. We would like to say thank you all the speakers and for their excellent presentation, and also all the audience for your active participation. And I would like to return this session to the Dr. Eri. Thank you very much.
Okay, thank you, Dr. Gandhi, Dr. Dewiyani, and also Prof. Shoji. Thank you for all the speaker for the enlightening discussion about the liver pathology, and also thanks to our committee for the hard work for today's guest lecture sessions. Thank you for all participants who already joined this guest lecture sessions. This guest lecture session is presented by Department of Anatomical Pathology and also Clinical Pathology of Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Hopefully, you get a beneficial message for all the speakers today, and I see you again in maybe in the next event. Hopefully we will our department and in collaboration with other department will hold some other event. So thank you so much for your participations, and bye bye. See you again. Thank you, Prof. Thank you, Dr. Gandhi.
Thank you very much.
Gandhi. Thank you
very
all.
much.
Thank you very much, Dr. Eri, Dr. Rusdi,
Yes.
Professor Shoji, and Dr. Dewiyani.